Hey guys, Dr. Carmen Bryant here with another video for y'all on today. We're going to be covering seizures. So we're going to talk about the the underlying causes, and then move on into the nursing interventions and medications. So just a real simple brief patho about seizures. So what is actually happening inside the body when a seizure takes place? It's basically an imbalance between two types of neurons within your brain. You have neurons that secrete neurotransmitters that cause inhibitory responses, and you have neurons that secrete neurotransmitters that cause excitability. The inhibitory neurotransmitter is something called GABA, whereas the excitable or the excitatory neurotransmitter is something called glutamate. So there's either an excess activity or excess glutamate being secreted, or a lack of GABA, that inhibitory neurotransmitter being secreted. So there's an imbalance between those two. So that's basically what happens, and that becomes, turns into an area of focus within the brain that becomes hyperexcitable, and then seizure activity, is the result. So the underlying causes in adults, I want you to think back to when you learned about reversible causes that cause cardiac arrest, the H's and the T's, if you will. So it's kind of the same concept when we think about seizures that take place in adults. There are many reversible causes. Not every single seizure that happens in the clinical setting, the ICU setting in particular, is because of a chronic epileptic disorder. The majority of seizures that occur in that setting are because of some type of irreversible cause. And so we have the acronym vitamin D and E to help you remember those reversible causes. So the V stands for vascular causes. This could be strokes, ischemic stroke to some degree, but mainly hemorrhagic strokes, because hemorrhagic strokes significantly increase ICP. So also you want to think about hypertensive encephalopathy as another vascular cause for seizures. The I is for infections, and that's going to be encephalitis, which is a direct viral infection of the brain tissue itself, or meningitis, which is an infection of the meninges that cover the brain. The T stands for trauma, so think of traumatic brain injury. A, that stands for autoimmune disorders, so systemic lupus erythematosus, get tongue twisted there, and also paraneoplastic syndromes, where there are ectopic hormones and things being secreted that cause excitable foci to form in the brain and lead to seizure activity. So autoimmune, think of lupus, think of paraneoplastic syndromes. The M, that's a big one, that stands for metabolic issues. So when you're thinking about metabolic, you want to think about things like hypoglycemia, all right? You also want to think about things like hyponatremia, okay? So the hyponatremia, leads to the cerebral swelling, and can absolutely lead to seizure activity. So those are two of the main metabolic causes of seizures. Also, when we want to think about our liver patients, our renal patients, buildup of urea, which is a waste product typically eliminated by the kidneys, and ammonia, which is typically eliminated by the liver. When those waste products build up, those can lead to seizure activity as well. But the two biggies, hypoglycemia, hyponatremia. The I, that stands for idiopathic. So we're going to lump the people with chronic epilepsy into the idiopathic category. And 9 times out of 10, it's those people with chronic epilepsy that have missed a dose or two of their seizure medication, and they go into seizure activity. The N stands for neoplasia, so that's cancers, any cancer of the brain, Glioblastomas are notorious for causing and leading to seizure activity. D, so this is a big one. This stands for drugs. Well, I'm not going to go over every single drug that leads to seizure activity. There's a little mnemonic, and it's called Otis Campbell to help you remember some of the biggies. So the O stands for opiates. The T stands for tricyclic antidepressants. The S is salicylate, so that's aspirin. The C, cocaine. A, amphetamines. The B and the E I have circled here. I skipped over the P, didn't I? P is for penicillins. That's another huge, we give that all the time, right? The B and the E I have circled. B stands for barbiturates or benzodiazepines, either one, and E stands for ETOH. And these drug categories themselves do not cause seizure activity. It is the withdrawal from these substances that can lead to seizure activity. Delirium tremens is huge in people with chronic alcohol dependence, and when you remove that alcohol, that CNS depressant, when you abruptly remove that, then they can go into delirium tremens and suffer actually fatal seizures. And then finally, L stands for lithium. All right, so that's a very brief a very brief overview of the reversible causes, if you will. So we'll talk about now the different stages of seizure activity. So we have here the prodromal stage, the aura, the ictal stage, and then the post-ictal stage. So anybody that has a history of seizures, epilepsy, seizure disorder, they'll know when these, signs and symptoms that manifest during these prodromal and oral stages, when they're coming on, and that kind of alerts them that, hey, a seizure is probably coming. So the prodromal stage can occur up to days before the actual seizure activity. And the prodromal stage can consist of anything like just an overwhelming depression, a sense of anxiety, insomnia, even GI or GU disturbances. The oral stage, the aura can occur, within minutes of the onset of the seizure. And the aura, it can vary widely from patient to patient. Most likely we're going to see an aura with those tonic-clonic seizures, some of those focal seizures, and an aura can mean for one patient, that they have visual hallucinations, or they have weird auditory sensations, or a weird taste in their mouth, or a weird smell. They may have the inability to speak or something like that. So it can just vary widely. And again, if you have somebody that has a seizure disorder, ask them what an aura typically looks like for them, so you as the nurse can be prepared for that. Then we have the ictal stage, where the patient is actually seizing. It's very important to time the onset of the seizure. Typically the ictal stage lasts anywhere from 1 to 3 minutes. We do not want the ictal stage to continue past 5 minutes, nor do we want patients to have seizures back to back to back. Then we enter into an emergency situation, and it's called status epilepticus. So that's why it's very important to time your seizures, okay? And anything past 5 minutes requires immediate medical intervention in the form of medication. And then finally, the ictal or the post-ictal stage can last for hours or even days, especially these patients that have those tonic-clonic generalized seizures. And that can look like anything from just kind of a lasting confusion to just an overwhelming kind of sense of fatigue, maybe a headache that persists. The patient might have suffered an injury. They might have bitten their tongue or hit their head during the course of the seizure. And so that's kind of the post-ictal stage. Now, I will say the only generalized seizure that typically won't have this post-ictal stage are these absent seizures that we see in the pediatric population. And once the seizure is over, they kind of just snap right back into what they were doing. All right, so that's the stages. So now let's discuss the different types and categories. I've got them divided up into two broad categories, either generalized or focal. And so with generalized, this means that the seizure is affecting both hemispheres of the brain. All right. With focal seizures, only a very small portion of the brain, maybe even one small portion of a lobe, is being affected. All right. So the types of generalized seizures, tonic-clonic is going to be the most common, the most well-known, the most taught about, and probably one of the ones where there is the highest risk for injury. And so tonic-clonic seizures look like in the tonic phase where the patient, they have very, very stiff tone, okay, and otherwise tonic. So they're very, stiff. Their entire body is very stiff. And then they'll go into these very violent convulsions in that clonic stage, okay? So tonic and then clonic, where the entire body is involved. So that's the tonic-clonic seizure. You can have a tonic seizure where the patient is just very stiff and has that stiffening of their entire body, and they don't ever go into the clonic phase. Or you can have the clonic phase by itself, where it's just rapid, large convulsions of the body, of the legs, of the arms, okay, of the whole, the back, every part of the body is involved. So you can have tonic-clonic, where it's the tonic combined with the clonic. You can have tonic by itself, or you can have clonic by itself. They are all considered generalized seizures. Another type of generalized seizure is referred to as atonic. A means absence of, tonic means tone. So in an atonic seizure, the patient's body loses all tone and they go very limp. And the risk here is that the patient will fall. And most likely they're going to fall in a forward fashion and hit their head. And so these patients a lot of times will be required to wear helmets if they have recurring atonic seizures. The next type we have here is myoclonic. So myo refers to muscle. And so these are just repeated, very short, rapid, jerky movements of the muscles, okay? And then finally, the absent seizures, which I touched on briefly. This is where, mainly this affects the pediatric population. They may be sitting in class. They may be at home working on a puzzle, and they just appear like they're totally, the lights are on, but no one's home. They are totally unaware of what's going on while this seizure is taking place. They have lost awareness. Once that seizure is over and resolved, like I said, there is no post-ictal phase there. They're going to snap right back into what they were doing with no memory of what just happened. A myoclonic seizure, you don't lose consciousness with the myoclonic type of seizure. Typically with your tonic-clonic and the atonic seizure, there is loss of consciousness. But these are all called, or they're all classified as generalized seizures. Again, meaning that both cerebral hemispheres are affected. All right, so now moving over here to the focal seizures, where only a small portion of the brain is affected. And I have those further broken down into simple partial or complex partial. And what you need to know there is mainly the difference between a simple partial and a complex partial is awareness. And with simple partial seizures, the patient remains aware throughout the seizure. With complex partial seizures, the patient loses awareness during that seizure activity. So that's the main difference. For whatever reason, simple partial seizures typically tend to affect the occipital lobe. So there will be visual changes, that accompany a simple partial seizure. Sometimes a simple partial seizure will then progress to a complex partial seizure where then the patient does lose awareness. In that instance, that is considered an aura to the complex partial seizure, okay? So if a patient has, say, a visual disturbance or some type of, inability to speak or some kind of interruption in speech or something like that, but they're aware, but then that progresses into a complex partial seizure where awareness is lost, we then consider that an aura preceding the complex partial seizure. So with a complex partial seizure, you will have unawareness, like I talked about. There are going to be motor signs and symptoms. Those are called automatisms. So the patient, again, is unaware of what's going on. They may be smacking their lips. They may be grasping at things with their hands. They may be, trying to grab something that's not there, or, just different motor movements that they're completely unaware that they're happening. Okay. So, if you think about this, the biggest risk for injury obviously lies over here with the generalized seizures, right? So that's an overview of simple patho, the reversible causes, the stages, and then the types. So we want to talk a little bit about kind of the diagnostic studies. So the physician is going to order, a battery of tests for patients that suffer a first-time seizure. A CT scan, if we're thinking there might be some sort of mass, or, there's been a stroke, or, an MRI to get, a clearer picture of the brain, like I said, to nail down some of these reversible causes. Obviously a tox screen if we're suspecting drugs are the culprit. Eclampsia, obviously that one's pretty easy to pinpoint, right? Infection, we might do a lumbar puncture to, test further if there's meningitis or encephalitis going on. They might do a battery of tests for autoimmune disorder or paraneoplastic syndrome. The metabolic, we need to do obviously a point of care glucose. We need to send off a BMP to look at different electrolyte levels, in particular sodium. And then neoplasia, like I said, CT, MRI to look and see what's going on. Now your EEG is going to be the diagnostic study of choice. It's like the EKG for your brain. It shows the electrical activity of what's going on in your brain. And it shows, it will reveal seizure activity in patients that are unconscious. And the most important thing, that you need to prep the patient for, there's going to be lots of sticky electrodes, in their hair, and there's not really, the patient doesn't have to be NPO or anything like that. But stimulants or even seizure medications don't need to be given prior to an EEG. Because if we give a seizure medication and then send somebody for an EEG, or they come up and do an EEG, that seizure medication might mask what seizure activity might be picked up on that EEG, if that makes sense. So what can we, do about this other than medications? There's something called a vagal nerve stimulator that, can be inserted, that can actually stimulate the vagus nerve and kind of calm seizure activity down. Very drastically, a craniotomy can be performed, where maybe that, irritated focus of the brain is removed, or if there's a neoplasia, in the brain that needs to be removed. But as far as nursing interventions, so when we have someone that has any of these, risk factors, we want to put them on seizure precautions, correct? So what do seizure precautions actually entail? So many things. We obviously want to make sure that their bed is in the lowest locked position. We're going to pad the side rails to prevent injury. We are going to remove any restrictive clothing. We're going to absolutely avoid restraining these patients. We're never going to put anything in the patient's mouth during seizure activity for them to bite down on. During a seizure, always we're going to turn our patient to the side in case vomiting or blood or whatever were to arise. Then that patient needs to be placed on their side to protect that patient's airway, because airway is always our number one priority. We also want to make sure, again, that we are timing the seizure, right? So we want to make sure that we're not reaching that 5-minute point, because then we've moved on to a different, we've moved into a medical emergency situation that needs to be treated with emergency medicine. We need to make sure that there is suction equipment at the bedside and oxygen at the bedside if the patient's not already on oxygen. We need to make sure that there is possibly a nasal trumpet at the bedside in case we have to bag this patient. A nasal trumpet is something that we can use to help open the airway for our patients that are seizing. Obviously, once the seizure has completed, we want to do a complete neuro check. We want to get a complete set of vitals. Our work is not done there. Once the patient has completed the seizure or has stopped seizing, and obviously we want to continue to implement seizure precautions. So on this side of the board, I've already talked about seizure precautions. So the basics: oxygen, suction equipment at the bedside, bed lowest locked, padded side rails, nothing in the patient's mouth, no restrictive clothing, do not restrain the patient, always turn the patient on their side. Now, medications. So we talked about status epilepticus, which is a medical emergency, and we've got to get these patients to stop seizing because during that time their brain is without the supply that it needs. So the first line of medication therapy that we're going to try are our benzodiazepines. So that's your PAMs, your lorazepam, your midazolam. And obviously those carry the adverse effects of heavy sedation, but they're really good drugs. They're typically our first line drugs to try to reverse status epilepticus. Next, we're going to move on to phenytoin. And fosphenytoin actually in the last few years has proven to be or have less side effects. We can infuse it more rapidly than phenytoin. There's less cardiotoxicity, there's less tissue toxicity with that drug. So a lot of physicians will order that one. It's also called Cerebex. Cerebex is the trade name for that one. Levels on phenytoin. I always tell my students, if a drug has the ability to draw a serum level on it, you need to know that drug for NCLEX because it's an important drug. If it's important enough that we need to know the therapeutic level by drawing those levels, then you need to know that drug frontwards and backwards. So phenytoin, the level is going to be 10 to 20. That's a therapeutic level of that one. So next, that's not working. They're still seizing. We're going to go ahead and go to phenobarbital. That's a barbiturate. Obviously, heavy sedation is an issue with that. Hypotension, all the things that come along with that. Hepatic toxicity. It is excreted through the liver, so it is to be used in caution in patients with hepatic toxicity and also renal failure, because about 15 or 20% of it is excreted through the kidneys as well. So keep that in mind. And then finally, propofol, that's like our last ditch effort, right? But if we start a propofol drip, the patient will have to be intubated. But propofol will get the job done, right? So over here, I've talked about these are the drugs that we use for status epilepticus. These are drugs, you know, that typically they're going to be sent home on. Valproate or valproic acid, Depakote, those are all the same drug, different names. Just kind of watch out for hepatic toxicity with that one. And then levetiracetam, that's also called Keppra. The Keppra is the trade name there. The issue with Keppra is agranulocytosis, okay? So it likes to eat white blood cells. And so with that in mind, we have to kind of remember that these patients might be at a risk for, you know, immune suppression and things like that. So we have to monitor their CBC, their white blood cell count, if they're on that drug long term, all right? So that kind of wraps up a whole lot about seizures. So we've talked about the a brief patho of glutamate versus GABA, the reversible causes, and how, you know, we kind of test for those with different diagnostic studies, the difference between the types of generalized seizures and the focal seizures, and obviously what seizure precautions entail, as well as the medications used for status epilepticus and the medications that are just used for long-term seizure control for the most part. And so I just hope that y'all have found this video somewhat helpful. Be sure and browse around NursingSchool911.net for more videos, more helpful resources. And I just hope your semester is going great. And thank you guys so much for watching.